Good morning, everyone. So, was a good time to start? Anybody? Second. The neuromodulation in underactive bladder, is there any role? We know the neural influence on the bladder, both the sympathetic and parasympathetic from the spinal level. And we also know about the cortical influence on the bladder. And it has been time and again tested and tried to modify it via the means of sacral nerve, tibial nerve, and pudendal nerve. Here in the consecutive talk, I am going to stress on the tibial nerve. So transcutaneous tibial nerve stimulation is something that we do. Tibial nerve is a mixed nerve, sensory and motor as well. And this we have 2 points where we usually stimulate the tibial nerve. And this, because the tibial nerve is chosen now because it shares the same sacral supply with the bladder, and thus leads on to the neuromodulation. If you look at the studies that have been done, the number of studies in detrusor underactivity versus overactivity, detrusor overactivity studies are almost 6 times as the underactivity. And our very favorite Bible, the Campbell, does not even mention tibial nerve stimulation in the armamentarium against detrusor underactivity. And tibial nerve stimulation has got approval back in 2005 and 2018 for non-implantable and implantable. So the question arises, to determine the effects of neuromodulation by transcutaneous tibial nerve stimulation in patients with underactive bladder. It was a retrospective study now center from January 2013 to May 2022, where younger patients who had LUTs due to underactive bladder and had failed conservative management and were ambulatory were included. And those patients who were excluded with prior use of Botox, placement of pacemaker or implantable defibrillator, active UTI, past treatment with neuromodulation, or even surgical intervention on the bladder of any kind. So this is the neuromodulation machine that we use. All patients usually get weekly sessions for 12 weeks, and they usually get a 30-minute schedule. And the voltage is from 50 to 200 milliamperes and frequency from 5 to 200 hertz. All the patients undergo baseline evaluation with symptoms, uroflowmetry, PVR, and cystometrogram parameters. They are given neuromodulation with the protocol for 12 weeks, and then they were again repeatedly evaluated. We have recorded in a case record form the neuromodulation setups used and the follow-up data, and thus the data collected were statistically analyzed. There were 76 patients, the mean age of whom were 10.5 years, and males were almost 1.2 times in the females. Based on the pre-neuromodulation UDS, 50 patients, accounting to almost 65% of the patients had detrusor underactivity, and the rest of them had overactivity. The spinal cord deformity patients comprised of almost 30%, and other spinal total of almost half of them, and the rest of the half of them had PUV and bladder dysfunction. So when seen in 50 patients with detrusor underactivity, the same numbers were 19, 8, 12, and 11 respectively. So we already know about the neuromodulation changes in the storage phase, but look at the value phase, how the flow has improved in Qmax, and we also noted a slight improvement in the pediatric max as well. There was a patient, international patient who had arranged a protein machine, and look at the pre-neuromodulation and post-neuromodulation value phase, how the flow has improved significantly, but we also wanted to see the change in the pediatric max as well. So data-wise, what we found that there was statistically significant improvement in number of incontinence episodes, the procedural residue, the Qmax, and the number of CIS episodes as well. When seen and analyzed separately for those with intact spinal cord and those with individual bladder, there was no difference found in the number of frequency or the value volume after neuromodulation, but the number of post-void residue had come down with a statistical significant figure, which translated into a decrease in the number of CIC episodes. Here in this bar diagram, the blue bar corresponds to the pre-neuromodulation and the red bar corresponds to the post-neuromodulation. So in the neurogenic bladders, there was no significant difference in the incontinence episodes, but in those with intact integrity, there was a significant difference in the number of incontinence episodes. And this was also reflected when nocturnal incontinence was separately analyzed and compared. Coming to Qmax, again in the neurogenic bladder, there was no significant improvement in the Qmax. Whereas in those with intact bladder, Qmax had significantly increased from 7.1 to 11.8. When we invest for the period max, there was a slight improvement in the period max, but that did not reach the statistical value. Speaking of, so as a conclusion, what we want to say is transcutaneous T-valve stimulation has led to an improvement in Qmax for decrease in PVR, CIC, and incontinence episodes in intact spinal cord patients, but those with spinal cord deformity did not have significant effect. Lastly, I'd like to encourage everyone to have more research on this fascinating matter. Thank you.